I'm going to get
So
those
I'm
links.
broadcasting now. Share the screen. Can you see my screen correctly, guys?
Yeah, I can.
Okay, great. Share my computer sound. Great. Okay, so we have people joining. And here they come. Once we hit broadcast and we go live,
Welcome.
they all start popping in. So excited to have everybody here tonight. For anybody who is here in the US, hope you had a nice long holiday weekend. We did.
Absolutely.
We definitely did.
And hello, everyone. If you want to let us know and sound off in the chat and let us know where you're joining us from, we'll start to shout out where everyone is tuning in from.
I am in Florida. Dominga.
I'm in Missouri.
And Dr. Neptune is, of course.
Yeah, I'm in Baltimore, and I just want to say hello to our larger community of persons with Marfan syndrome and related disorders, and caretakers and interested parties. And I am here this evening to provide you with as much information as I possibly can, and I'm delighted to be here.
Great. Well, we're going to do that again once we officially start, but it looks like we have Monica, who's in New York, and Christy. Of course, Christy's on.
Hi, Christy.
And Monica, I go back with Monica a very long time. She's been with the foundation. She's been a member of the foundation for a very, very long time. So it's nice to see her here throughout this summit. We have a lot of people on. Let's see if I can tell who they are. I don't know if I can tell who they are. I don't want to screw up this whole thing here. So
welcome, Lorna from Canada.
It's 7:30, but we're going to wait another minute because I see a lot of people coming still.
Okay.
We have Valerie in New Jersey, Sarah in Utah.
Have you seen that over the course of the presentation that people join throughout? Is that how it happens? Or?
They mostly join right in the beginning. We get a huge amount, and we've looked at the data, and people stay. Sometimes they peek to look at the other sessions that are going on at the same time, but they come back. So.
Yes. Oh, and also Rebecca, just going to shout you out. You are in the right place. She has a son who is 4 with Marfan syndrome and was just diagnosed with mild sleep apnea. You are in the definite right place. Thank you for joining us.
We'll have answers for you. You'll put the questions in the Q&A box. Maybe wait until you hear the presentation because maybe your questions will be answered. Now,
will I be able to see the presentation, the questions, or will you just?
I'm going to read them. I'm going to read them out. It's easy. It's better that way.
Okay.
We have a lot of questions in the Q&A box already. People are still joining, so we're going to give it another minute.
Okay.
I'm watching
you
them come in here.
You have a fellow Floridian, Eileen, Joanna.
Oh, who's in there? Let's see. Let me check that out. Hi from Florida. Oh, Joanna. Yeah, I know Joanna. She lives near me. Hi, Joanna. Great to see you.
So I'm new to Missouri, so anyone joining us from Missouri, I'd love to e-meet you. I'd love to e-meet all of you, but a little biased.
Yeah, people are still joining. A lot of people wanted to attend this, so we'll just give it another minute or so. I don't want to use up any Q&A time at the end, but I'm gonna wait another minute because I see people coming in.
Yeah, I'm not in a rush. Don't worry.
Okay, great. We have a great presentation for you tonight. Dr. Neptune's talks are always very popular and very informative.
Oh, that's sweet.
So, yeah, it's always great to work with you.
Well, I love working with you guys.
Yay.
So let me just say that while we do the presentation, we'll all have our videos off, and then they'll just watch the presentation, and afterwards, Dr. Neptune, you'll put yours back on. So, all right. So why don't we get started here? Because all these other people are here on time. So going to the first slide here, I'd like to formally introduce myself. I'm Eileen Michelli, and I'm the Chief Program Officer for the Marfan Foundation. I also want to introduce my colleague, Dominga No, who will be posting in the chat box, as you might have just heard, and she'll be in there, providing you with some important links and some additional information that will support tonight's presentation. So welcome to the third and final week of the International E3 Summit, Educating, Empowering, and Enriching Our Community, brought to you by the Marfan Foundation and our divisions, the Loeys-Dietz Syndrome Foundation and the VEDS Movement, and our partners in Europe at CERN. Okay. Okay, 1 second. There we go. We are making history, and I'm so glad that you're all part of it. It's very historic. It's by far our largest event in our almost 40 years of existence, with nearly 2,800 registrants from more than 72 countries. We hope that you've had an opportunity to connect with people from all over the world in the app, and that you can maintain these connections after the summit. As you surely know now, you are not alone on this journey. We'd like to thank our presenting sponsors, Brigham and Women's Hospital and American Communications Construction based in Houston. Because of their support, we're able to offer programs like this to all of you at no cost. And we really want to make sure this information is accessible to you and that you hear from the best and the leading experts in the world. So we really thank our sponsors for their support. Before we get to the presentation, a couple of things I want to point out. I want to let you know that this International Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation or VEDS. If you hear differences of opinions from speakers and want further clarification, please contact our help center at marfan.org/E3ask and be patient as the volume is high during the summit. And before we go on to the presentation, I just want to remind you that your feedback is really, really important to us. It tells us how we did, but also what else you want to know and what else you'd like to learn. So after this session is over, please go into your app, and right there where the arrow is pointing, where it says rate, click on that, and it'll ask you some basic questions, and you can give us feedback on this presentation. So as we noted before, there's also that Q&A box next to the rate box, and put your questions in there for Dr. Neptune, and we're going to do our best to answer as many as we can. So without further ado, I'm going to shut my camera off. Let me shut my camera off and then we're going to move on to Dr. Neptune's presentation.
Hello, my name is Enid Neptune, and I'm at Johns Hopkins School of Medicine. I'm a pulmonary and critical care specialist, and I'm going to talk to you today about respiratory concerns in Marfan syndrome and related disorders. The most common symptom that prompts a referral to a pulmonary clinic is shortness of breath. In the context of Marfan syndrome and related disorders, this can be caused by several other issues, including cardiac disease, deconditioning. But today I want to focus on some of the etiologies and diagnoses that lead to shortness of breath and respiratory symptoms in patients with Marfan syndrome and related disorders. Now, in the interest of time, I'm not going to be able to cover all of the possible diagnostic possibilities, but I want to cover the ones that are the most common, which I've listed here. First, we have chest wall deformities and respiratory muscle weakness, which I'll cover under the heading of restrictive lung disease. Second, we have enlarged air spaces such as emphysema and pneumothorax, which I will cover under the heading of pneumothorax. And lastly, I'll discuss sleep apnea syndrome. Now, restrictive lung disease is much more common in Marfan syndrome and Loeys-Dietz syndrome than it is in vascular EDS. Up to 50% of patients with Marfan syndrome have some degree of restrictive lung disease. Now, these typically reflect musculoskeletal abnormalities of the chest wall. Effectively, the lungs cannot expand fully, and the symptoms can range from asymptomatic states to shortness of breath with exertion, and if severe, low oxygen levels or cyanosis, and heart strain. Now, this picture depicts someone undergoing pulmonary function testing. This is an old picture, but it's actually one of my favorites. And it shows that spirometry or pulmonary function testing is required to make a diagnosis of restrictive lung disease. And that is because we can measure specific parameters that are helpful in making the diagnosis using this type of test. First of all, we can measure the volume of air that you can blow out if you take a big breath in, and that's called forced vital capacity. We can also measure the volume of air that you can blow out within a defined period of time, such as 1 second. And thirdly, we can measure the total volume of air in your chest if you take a big breath in and hold it. Now this slide shows one of the tracings that we're able to generate with a pulmonary function test. And on the y-axis, we see flow, and that's airflow. And on the x-axis, we see volume. And so this is what's called a flow volume loop. And what you could imagine is that if you take a big breath in, you start here, and the breath will end here, and that's the total volume you're taking in. And then you'll be asked to blow it out. And you start blowing it out, and that generates what we call a flow volume loop. And what you can see is that the volume here is the normal volume that a person would blow out during this maneuver. In someone who's restricted, the volume is significantly reduced, and that shows a reduction in lung capacity, and that gives you the diagnosis of restrictive lung disease. Now, what causes restriction? These are the 3 diagnoses that we're going to be discussing today. And these are the ones that are most operative in patients who have Marfan syndrome and related disorders. Those are scoliosis, Pectus abnormalities, and respiratory muscle weakness. In terms of respiratory muscle weakness, another way of describing these disorders are neuromuscular disorders. And Marfan syndrome and Loeys-Dietz syndromes are both associated with skeletal muscle weakness. Although we typically think about skeletal muscles as affecting our arms and our legs, it turns out that our respiratory muscles are also skeletal muscles. And weak respiratory muscles can lead to reduced lung capacity or restriction. Now, how do we make the diagnosis? Well, we make it first with pulmonary function tests, which I showed you before. But we add on to the pulmonary function tests 2 specific parameters. Those are maximal inspiratory and maximal expiratory pressures. Now, you will see these parameters come up again later in the talk. And when you see them come up, remember that those are associated with respiratory muscle strength. So once you make a diagnosis of respiratory muscle weakness, how do you treat this? Actually, the most effective way of treating this is with pulmonary rehabilitation. If respiratory muscle weakness is very severe, some form of ventilatory support may be needed, but that's relatively uncommon. The next disorder I want to discuss are Pectus abnormalities. And these are far more common in Marfan syndrome and Loeys-Dietz syndrome than they are in VEDS. And they range from Pectus excavatum, which you see here, which is depression of the sternum, to Pectus carinatum, which is a deformity in which the sternum projects outward. Now, one should know that Pectus excavatum is the most common congenital disorder of the chest wall. So it's quite common in the non-Marfan population. But up to 2/3 of patients with Marfan syndrome have some evidence of a Pectus deformity. The natural history of Pectus deformities are typically benign, but there have been relatively few studies in a Marfan population or in any other syndromic disorder. Usually, these deformities are associated with only a modest reduction in lung function. However, while lung function is often the major consideration for repair, the cosmetic considerations are typically of greater concern and more reliably addressed by interventions. And so what this means is that if one undergoes a Pectus repair procedure, it's much more likely that the cosmetic results will be what's desired than the functional results. Now, how does one treat a Pectus abnormality? It's becoming clear that the Nuss procedure is the most desired procedure for most persons with Pectus deformities. And this involves the insertion of a metal bar that's curved underneath the sternum, as we see here. This bar is rotated and pushes out the sternum and the anterior chest wall, and is able to approximate kind of a normal contour of the anterior wall. The advantages of this procedure, which is a minimally invasive procedure compared to an open surgical procedure, is that it's easier, it's shorter, and is associated with fewer complications. And there's been at least 21, 22 years follow-up of patients who initially had this type of procedure. And the anatomic results have been durable, but there's been limited lung function data, particularly in patients who have syndromic disorders like Marfan syndrome, Loeys-Dietz. So one of the questions that I'm often asked is, does correction of Pectus deformities improve lung function? Probably not. However, we don't know whether these procedures may stabilize lung function in certain situations. A consideration is that the complexity of chest wall defects, especially if the Pectus deformity is associated with scoliosis and is also in a person with a syndromic disorder like Marfan syndrome, that context, that constellation may likely lead to more accelerated lung dysfunction without repair. So in that situation, one should proceed with the detailed assessment of functional capacity, such as a 6-minute walk test or cardiopulmonary exercise testing, and strongly consider an intervention if there is a progressive decline in these measures. Let's move on to scoliosis. Now, scoliosis is very common in Marfan syndrome and Loeys-Dietz, and not so common in vascular EDS. And this is the circle that describes the factors that are associated with progressive lung dysfunction in a person who has a diagnosis of scoliosis. And that includes the age of onset. Earlier onset is worse than late onset. Sleep-related abnormalities, inspiratory muscle weakness, which we discussed when we talked about respiratory muscle weakness, underlying etiology, and this is a surrogate for syndromic disorders. And lastly, a large Cobb angle, which describes the degree of curvature. On this slide, we show how the Cobb angle is measured. And it's largely measured by describing the angulation of the curvature in the spine on plain films. And what's important is that thoracic curves are worse than thoracic and lumbar curves because they affect kind of the lung capacity much greater than lower curves. On this table, we describe some of the considerations with greater degrees of curvature. Now, these rules are not hard and fast, but they give us some sense of when we should consider surgical intervention. And that's typically when the curvature is greater than 40 or 45 degrees. And that's because with greater levels of curvature, there is a much greater likelihood that there will be respiratory compromise. So what is the pulmonary evaluation of scoliosis? First, we need to perform a full set of pulmonary function tests, and that includes the tests of muscle strength that we described before. In addition, there's a test we call a sniff fluoroscopy, and this is a test that we do using x-rays to describe the function of the diaphragm, which is also a respiratory muscle. We recommend a 6-minute walk test or a cardiopulmonary exercise test, again to assess exercise capacity. And quite often we also ask for a sleep study, especially if the patient has snoring or any type of sleep derangement. Now, what are the treatments for scoliosis? Well, first of all, there are dual goals of intervention. So you want to prevent further structural deformity, and you also want to preserve or improve pulmonary function. And the two types of intervention are either bracing or surgery. And our orthopedic colleagues will go into great detail about the surgical options in another webinar and talk in this series. But what's important to understand is that bracing is typically considered when there is progressive curvature that's less than 45 degrees of a Cobb angle. And surgery is typically considered when there's progressive curvature despite bracing, there's a large Cobb angle, and or there's evidence of some respiratory compromise. And so let's summarize the diagnoses that are associated with restrictive lung disease. They could be due to pectus deformities, and here surgical repair does not correct restriction, but may stabilize kind of the degree of lung function. And cosmesis should dictate repair unless there's a severe deformity. Scoliosis, this is typically corrected early. There is progressive curvature without correction, and pulmonary consequences without correction of a severe thoracic deformity is probably quite significant. And lastly, neuromuscular disease. And for this, we should strongly consider pulmonary rehabilitation, and if severe, consider some ventilatory support approaches. So the take-home message is that we need serial pulmonary function tests to follow the progression of pulmonary restriction in patients who have Marfan syndrome and related disorders. And there should be functional assessments associated with pulmonary function testing in order to determine whether further interventions are needed. Appropriate surgical interventions for scoliosis may prevent or delay further deterioration in lung function. And a pectus repair should be driven by cosmesis unless complex chest wall deformities or significantly reduced lung function are found. Let's move on to pneumothorax. And this is much more common in Marfan syndrome and vascular EDS. And we do not know the prevalence in Loeys-Dietz syndrome. And that's hopefully something we'll be able to determine in the years forward. So what is pneumothorax? Pneumothorax is effectively lung collapse. And it occurs when the lung detaches from the chest wall. What are the symptoms? Typically acute onset of pleuritic chest pain. And pleuritic pain is pain that you get when you take a big breath in or when you cough. Shortness of breath and a dry cough. How is it diagnosed? Typically with some imaging study such as an X-ray or a CT scan. This slide depicts what happens with the pneumothorax. So there's typically some type of rupture on the surface of the lung, and this could happen because of direct trauma, or it could happen because the lung is very fragile, which is the situation with Marfan syndrome. And so air escapes from the lung proper and goes into what we call the pleural space, and that effectively compresses the lung and causes the collapse. We see this again on an X-ray here. This is air, this is a collapsed lung, and this is what a normal lung looks like on the other side. It's important to know that pneumothoraces are frequently bilateral and recurrent in both Marfan syndrome and VEDS. And it's also important to know that pneumothorax is the initial manifestation in many cases of VEDS, and it develops because of hemorrhagic nodules and hemorrhagic cavities, which I'll show you. On this slide, I depict some of the imaging findings that frequently lead to pneumothorax in Marfan syndrome and in VEDS. And here we see apical blebs, and these are basically large alveoli or large air spaces at the top of your lungs. And these form from alveoli, and they can be congenital, present at birth, or they can develop after blebs are resected. Over here we see in VEDS, this is a hemorrhagic nodule. So there was a bleeding area that became a nodule, and then it cavitated and now has a hole in the center. If this particular lesion is close to the surface of the lung, that can also cause a pneumothorax. So how is this treated? If it's small, hospitalization and supplemental oxygen are all that's needed. If it's moderate to large, a chest tube may need to be placed for evacuation. And that can range from a large chest tube, or what we call a surgical chest tube, to a small pigtail catheter, or even to what we call a pleurax, which is a catheter that you can actually take home with you and will evacuate over several days. If the pneumothorax is not responsive to these kind of maneuvers, a pleurodesis is indicated. And this is a procedure to basically tack up the lung so it doesn't collapse. Now, this can either be what we call a chemical pleurodesis or a mechanical pleurodesis. A chemical pleurodesis involves the installation in the pleural space of a chemical that causes extensive scarring. A mechanical pleurodesis is when the surgeon actually irritates the surface of the lung and then irritates the surface of the chest wall and basically puts them together, almost like creating a Velcro strip. In the setting of Marfan syndrome or related disorders, we very much prefer a mechanical pleurodesis to a chemical pleurodesis because many patients will ultimately need to have aortic surgery. And it's much easier to dissect through a pleural space that has a mechanical pleurodesis lesion than has a chemical pleurodesis scarring. Here we see on the left the types of lesions that predispose to pneumothoraces in patients with Marfan syndrome. These are blebs, and this is the surface of the lung. And you can see that these blebs are large, but their walls are really, really thin. And that's why they're much more vulnerable to rupture. And on the bottom, we see another kind of surface of the lungs without blebs, but with thinning of the wall and with enlargement of the air spaces, but without blebs. On the right, we see the surgical procedure where the bleb is opened up and then is basically sealed off and removed. And this is what's called a bleb resection. So the indications for surgery, which typically involves a bleb resection and mechanical pleurodesis, are these. So either there's poor re-expansion, the pneumothorax is recurrent, there's a persistent air leak with the chest tube, there's both a right and a left pneumothorax, there's blood in the pleural space, there's a tension pneumothorax, or there's large blebs and cysts. So the take-home message is that pneumothorax is a common manifestation of Marfan syndrome and VEDS. If it's recurrent, a pulmonary consultation should be obtained, and probably even with the first pneumothorax, if it merits hospitalization. One should observe surgical considerations of an eventual aortic repair using mechanical pleurodesis rather than chemical pleurodesis. And VEDS patients should have a procedure done at a center with expertise in connective tissue disorders, given the known fragility of their tissues. And we're going to end with sleep apnea, which we know is much more common in Marfan syndrome than the other disorders. But keep in mind that the other disorders have not been studied as much in the context of sleep apnea. The definition is an intermittent cessation of airflow at the nose and mouth during sleep. It affects 2% of women and 4% of men in the Middle Ages. And it's a cause of excessive daytime sleepiness. And it can either represent obstructive apnea, where you can't breathe against a closed upper airway, or central apnea, where you don't have the neural sensors that tell you to breathe. This slide depicts what actually happens anatomically with obstructive sleep apnea. And that is that the tongue basically relaxes during sleep and falls back against the airway, effectively blocking it. It's common in the general population, and it can be potentially life-threatening with high clinical impact, contributing to motor vehicle accidents, cardiac arrhythmias, heart attacks, and even aortic dissection. It can cause strokes, reduce productivity, and importantly, an overall reduced quality of life. Recent studies by our group and others have shown that up to 35% of patients with Marfan syndrome have some degree of sleep apnea. And the causes in the Marfan population probably involve a combination of the abnormal morphology of the face with differences kind of in the airway morphology or shape. It involves floppy upper airways and to some extent the chest wall abnormalities that we discussed earlier. Now, the major question is whether obstructive sleep apnea affects aortic enlargement and progression to aortic rupture and aortic dissection. This is an area that we're actively investigating at Johns Hopkins. And this is the mechanism that we think might be operative. We know that sleep apnea causes pressure changes within the chest when you're trying to breathe against a closed airway. It also is known to cause elevated blood pressure, and it also causes low oxygen, oxidative stress, and inflammation. And we suspect that the combination of these insults can cause aortic progression from enlargement to actual rupture and dissection. And we're engaged in multiple studies to examine this possible association. And we're also interested as to whether treatment of obstructive sleep apnea can prevent this progression from aortic enlargement to these more serious complications. Sleep apnea is typically diagnosed with a sleep study that involves a measurement of these particular kind of parameters. An apnea-hypopnea index is typically generated, and that is what gives one the diagnosis of sleep apnea. It can be mild, meaning that it's greater than 5 but less than 15, or moderate if it's greater than 15, or severe if it's greater than 30. We are finding that snoring may be an important risk factor for sleep apnea-associated aortic injury. So the symptom of snoring in a patient with Marfan syndrome-related disorder should be investigated. How is this treated? Well, nasal CPAP is the most conventional sleep intervention, which is used at night. This may be combined with supplemental oxygen. And if there's difficulty with the CPAP mask fitting, it's also reasonable to consider some of the dental devices that can also be effective for mild sleep apnea. For patients with Marfan syndrome, I typically advise exploring more than 5 masks with some type of a training protocol before you are deemed as being difficult to fit. And that is because sometimes just the facial shape can create some challenges with conventional masks. Weight loss is usually ineffective in the Marfan population, and surgery is rarely used. And this slide shows how nasal CPAP works. Basically, it generates a positive airway pressure that stints the airway open and allows normal airflow. And these are some of the devices that are available to treat sleep apnea. And they range from apnea pillows that can be combined with nasal masks or full face masks and a dental device that I talked about. So the take-home message is that sleep apnea is underdiagnosed in Marfan syndrome and may well be underdiagnosed in Loeys-Dietz and VEDS, but we just need more data. And all adult patients with Marfan syndrome should be considered for screening, especially if they have snoring, any type of sleep disturbance, or a chest wall deformity. And I will end there. And this slide shows our Marfan Sleep Health Initiative. And this is my contact information, and I will end there.
Wow, thank you so much. Let me stop sharing here. Thank you so much for that presentation. Dr. Neptune, if you can put back your camera, and then we can see you again and we can ask you some questions. Let me see, maybe I can do that.
Yes, it says you cannot start your
video. I bet I can do that. How about now? There you go. Okay, great. So actually, I am going to hide myself because we don't need to look at me. We have a lot of great questions here, and you did talk about a lot of the issues that people brought up in the Q&A box. But since people just really want to know more about this, so I'm going to maybe ask you to reiterate some of the points that you made. The last slide, you said Marfan, that sleep apnea is underdiagnosed in Marfan. Do you have any idea how common it is? Like, what are your thoughts?
Well, based on studies that have been by our group, actually, with the kind of enthusiastic participation of persons who attended our last Baltimore Marfan meeting, it's been shown that up to 40% of persons with Marfan syndrome have some degree of sleep apnea. Majority is mild sleep apnea. But one of the trenchant questions that we're pursuing at Hopkins, and we hope to kind of expand to the larger Marfan community, is whether those underdiagnosed cases, if they're untreated, whether they associate with kind of aortic injury. And so we're involved in kind of a study now where we're looking at the prevalence, and we're also looking at aortic dimension and progression in aortic dimension. And we invite anyone kind of in a larger community who's interested kind of in these sleep apnea issues to contact me, and and we'd be happy to share the information that we currently have.
Great. And so you did also mention that anybody with Marfan who snores, that should be a kind of a first red flag and a tip off maybe to get evaluated. How dangerous is sleep apnea? You mentioned if it's not treated,
Exactly.
There are definitely some serious repercussions. So how often do you see that?
It can be quite common in terms of the consequences of untreated sleep apnea. And one of the concerns is that because there are issues with mask fitting, that sometimes the Marfan population can get very, very frustrated with their sleep specialist. And what I want to do is encourage persons with Marfan syndrome to push their sleep doctors to provide them with multiple different masks so that they can find the one that works the best. And it's not going to be the first one. It probably won't be the second one. It takes a great deal of customization in order to find the one that works. And it's worth the time, because untreated sleep apnea in the setting of kind of a very fragile aorta could be quite problematic. And so I want to kind of be very aggressive with making the diagnosis and entertaining the available treatments that we know work.
And you at the top of your list of treatments for sleep apnea, again, back to CPAP, and you talked about that extensively. What about BiPAP? Somebody else asked about the BiPAP. What's the difference between those two?
Well, BiPAP is another mode of what we call non-invasive ventilation. And what BiPAP does is it delivers pressure both with inspiration as well as with expiration. And so it has not only the ability to stent the airway open, but it also has the ability to help ventilate, to help take a breath in and to breathe it out. And so in persons who have more advanced types of lung disease associated with sleep disordered breathing, BiPAP is often the intervention of choice. I do want to mention the snoring, because that's kind of newish data that we're just seeing in our current study of sleep apnea and Marfan syndrome. And one of the questions that we're investigating is whether we can use snoring as kind of a rationale to undergo sleep studies in the Marfan population. And so we're looking at the association of snoring with all of the other kind of correlates of sleep apnea. And we're finding very suggestive data, and we're continuing to study this, and hopefully within the next 6 months to a year, we'll have something that's ready for publication.
Oh, great. We look forward to that. So now moving on from sleep apnea, let's move over to asthma. Another big concern from people. Very popular question among our participants, inhalers. When do you use them and which ones should they stay away from? Are there any that are contraindicated in Marfan?
That's a great question. The challenge with the choice of inhalers is kind of the recognition that one of the kind of very, very common inhalers that are used with asthma in the non-Marfan population are what we call beta agonists. Now, most people are very aware of beta blockers, which are commonly used to reduce the injury to the aorta in patients who have Marfan syndrome. Well, beta agonists oppose the effects of beta blockers. So you have this kind of these two drugs that are battling. And that is the last thing that we want, because we know that beta blockers are very standard therapy to protect the aorta. And so I strongly discourage the use of what we call beta agonists. And you may ask, well, which drugs are beta agonists? Those are albuterol, Xopenex, Duonebs, Combivent, and there are other agents that can perform a similar function. What I kind of advocate using are what we call anti-muscarinics. And those are inhalers like Atrovent, Spiriva, Anoro. And those agents also provide kind of what we call bronchodilation or opening up of the airways without the opposing effects to beta blockers. So that's what I suggest. The other agent, which kind of helps over the long term with asthma, as well as other airway diseases, would be an inhaled corticosteroid. So my preferred combination for Marfan patients with asthma or a related condition would be an inhaled corticosteroid and an Atrovent inhaler that you use for activity or when you're feeling short of breath, and as we call it, a reliever inhaler.
Great, thank you. In a related question, what breathing difficulties are most likely with Loeys-Dietz or other heritable connective tissue conditions? Is there a breathing problem with symptoms like asthma, but it does not show up on regular asthma testing?
Asthma is a very challenging kind of disorder to diagnose because you can have totally normal pulmonary function tests and yet have asthma. So it's important that the physician get a very extensive medical history and also kind of get appropriate imaging studies and a good assessment of what the triggers are for the shortness of breath, cough, or wheezing. What we typically see with Marfan syndrome and Loeys-Dietz are kind of either disorders that relate to kind of structural lung disease, such as the blebs, such as kind of the increases in airspace size, or asthma, which is an airway disease. Sleep apnea has been much better described kind of in the Marfan population. We think it may well be kind of highly prevalent in the Loeys-Dietz population. We just don't have the data just yet. And in VEDS, there's no current signal that there's a high prevalence kind of in that population.
Great. All right, thank you. Now we're going to move over to another popular topic, COVID and lung disease. A few questions here. There seems to be a disagreement, somebody says, about whether and when connective tissue disorder patients are at increased risk for bad outcomes from COVID-19. For example, would a Marfan patient with moderate Pectus deformity and severe scoliosis be less likely to successfully use proning if it was indicated, which has, since we did our webinars, that's become more of a way to help people who are in the hospital. And so they're wanting to know about that, and then generally about the COVID-19 risk in connective tissue disorder patients who have lung issues.
A very good question also. I think it's very important to kind of separate the issue of whether a patient group is more susceptible to the infection versus more susceptible to the adverse outcomes of an infection.
Right.
So there's no evidence that persons with Marfan syndrome or related disorders have a higher incidence of developing the infection. But what we're concerned about, and especially as a pulmonary specialist, is that we know that COVID is a respiratory virus. In that way, its morbidity or its kind of health consequences are typically related to that of lung disease, lung function impairment, lung inflammation. And that's why most of the hospitalized patients are hospitalized because they have low oxygen levels or have what we call respiratory failure and need to be helped with a ventilator. With Marfan syndrome, there's a number of patients who have underlying reduced lung function. And that could be because of asthma, it could be because of blebs with pneumothoraces, it could be because of the scoliosis and pectus deformities that cause what we call restriction. And because of that, they have what those in the pulmonary community would call reduced pulmonary reserve. And so that means that if you have a pulmonary insult that is acute, and you could have that with a pneumonia, a virus, or any other kind of acute event that affects your lung, you will have lower reserve, and therefore there's a greater chance that you will have the low oxygen level, the respiratory function impairments that will land you in the hospital. And so the concern with Marfan syndrome is that if you in fact develop a COVID infection, you have a higher likelihood of requiring some medical care and possibly hospitalization. So that's why you have to be very conscious of whether you're exposed, whether you have kind of any new symptoms on top of your baseline symptoms, and then have a very low threshold to be tested and to be evaluated as to whether you need further care or even hospitalization.
And what I've heard from people I know in the community who have had COVID, that it does feel very different than their normal Marfan aches and pains or what they're used to on a regular level. So
yeah, and that's important. And the point I'd also like to make is that the Marfan Foundation and the larger community of kind of Marfan caregivers, we're very interested in the experience of persons with Marfan syndrome, Loeys-Dietz, VEDS, and other connective tissue disorders in the event that they do have a COVID infection. So please let us know kind of what your experiences are, you know, what the nature of your hospitalization was, just so we can build up a database and be able to further advise patients in the future.
Well, I'm glad you brought that up because Dr. Shireen Shaloub at University of Washington, through the Aortic Disease Collaborative, has a big study going on, and it involves a survey. And Dominga's going to put the link to that in the chat box so that people who are here can check that out. That's really important work that she just got a grant to do. So we're really excited about that. But the second part of that COVID question, I just want to go back to, it might not be you because it's more of an orthopedic issue maybe, but a Marfan patient with moderate pectus deformity and severe scoliosis, you know, this proning technique they're doing in the hospital, would a Marfan patient with those kind of features, would they be able to get in that position or be put in that position?
That's a really good question because proning relies on differences in the way that the lung kind of is ventilated in kind of a prone position. That's with your stomach down versus a supine position, and that's with your back down. And there probably are some differences in the physiology of someone who has kind of a significant pectus deformity plus minus scoliosis. We don't currently have the data on that yet. And that would be one of those permutations of these connective tissue disorders that would be really helpful for us to know. But one thing that's important is that if you have those chest wall deformities with scoliosis, that you have some assessment of your lung function. And if you have restriction, if your physician has said that your lung function is less than normal and significantly less than normal, then that would mean that you have a higher likelihood of having a low oxygen level, and therefore proning may be an intervention of choice in order to prevent you from needing to be on a ventilator.
Okay, great. I'm going to stay on the COVID theme here. I'm going to put you on the spot a little bit. I did give you a warning on this one. This person says, in March, presenters at a Marfan Foundation webinar on COVID-19, which was you, stated that connective tissue disorder patients who were more than a few months post-op from open heart surgery were at no increased risk from COVID. I find this difficult to believe since even post-op heart patients are still at increased risk for more cardiac problems. So I think there's some clarification needed here and some more explanation.
I think there's a question as to what the susceptibility factors are in terms of COVID morbidity. Morbidity means kind of the severe health consequences of the infection. What we do know, based on lots and lots of observational data from China, from Italy, from here, is that persons who have underlying cardiovascular disorders, and namely high blood pressure, coronary artery disease, congestive heart failure, have a much higher risk of requiring hospitalization and ultimately maybe requiring ICU care. Whether a subset of patients with Marfan syndrome who fall within those groups are similarly susceptible hasn't been fully resolved, but the foundation's posture is that if you have heart failure, if you have extensive vascular disease, and if you have kind of aortic disease without repair, then you may in fact be more susceptible to these adverse consequences. I think the controversy and maybe the confusion is whether the post-op state confers higher risk. And that's not something that's been very well studied. And it's something, it's something I will look into, and I will inform the foundation of what I find. But from these larger cohorts, that's just not a clinical context where we have a lot of information about.
We're learning every day about COVID. In like 6 months, we'll have a whole other set of webinars probably. So I know you'll be there for us then.
Of course.
I know. Okay, so moving on a little bit. What's your feeling on people with Marfan getting the pneumonia shot or vaccine?
I definitely think persons with Marfan syndrome who have any underlying pulmonary disorder or serious aortic disorder should have kind of the Pneumovax, and also should have the flu vaccine every year, because they fall into a risk group in terms of having chronic cardiovascular disease or chronic pulmonary disease.
Okay, great, thank you. If you have had a number of pneumothorax, are you more likely to have them again?
Yes, that's something that we're well aware of in Marfan syndrome, that the first pneumothorax predisposes you to subsequent pneumothoraces. And we can't always predict them simply based on whether there are blebs in the lungs, because you can have blebs that don't result in pneumothorax. So one of the active areas of my research is trying to determine what the structural factors are in the lung that associates with pneumothorax and recurrent pneumothoraces. We don't have guidelines just yet, and that's one of my priorities, that we can establish guidelines for the management of the first pneumothorax in persons who have Marfan syndrome and related disorders, because that should be distinct from those in the larger community who have a single episode of pneumothorax. And so that's one of the things that I hope we're able to get out there within the next few years.
I'm writing that down. I like that. I'm gonna follow up with you on that one.
You have
Here's another pneumothorax question. If a family member has a pneumothorax, and is there something that the non-medical family members can do to help the person while they're waiting for medical help or while they're bringing the person to medical facility?
That's also a really good question. And there aren't many people who have like an oxygen tank in the home with a mask that they can hook their family member up to an oxygen tank. So what I would advocate doing is to be reassuring and to be supportive that medical care is needed, because the symptoms of Marfan syndrome, symptom of pneumothorax, can also kind of reflect symptoms of other types of concerning disorders, including dissection, including kind of chest wall issues. And so you definitely want a medical evaluation to establish that this is in fact pneumothorax, and also to determine whether further interventions will be necessary in terms of kind of a chest tube to kind of evacuate the excess air, or to place you on 100% oxygen in order to help resolve the pneumothorax over several hours. So I think the family members should be supportive of getting further medical kind of assessment and aware of the fact that there are other diagnoses that need to be considered, even if one is totally convinced that one is having a pneumothorax.
Great. So we're getting to the end of the hour, but we're going to stay on a little bit longer. Dr. Neptune agreed that to spend some more time answering your questions, because there are so many of them. We won't go on forever, but we're definitely going to take at least 10 or 15 more minutes, because
you have my total attention and time.
Everybody's been waiting patiently to get their questions answered. So we're going to move on to somebody with VEDS. A teen with VEDS is reporting difficulty taking breaths, causing a strained feeling around the heart and draining energy. And they have been cleared of pneumothorax and pleurisy. Is there anything else they should be considering?
I think unusual symptoms with VEDS are not uncommon. And I know our incredibly energetic VEDS population realizes that they sometimes have to be very prescriptive with their physicians. And I would say if this is a symptom that's been persistent, that I would, one, request a referral to a lung specialist, and also suggest that you undergo pulmonary function testing to determine what the lung function issue is. Many patients with VEDS can have kind of an issue with kind of the cysts in their lungs that can form from episodes of bleeding with nodules, hemorrhagic nodules, etc. And so I've seen many patients who have VEDS that also have reduced lung function because of these kinds of events, some of which are clinically apparent and some of which are not.
Okay, great, thank you. As you know, we have a lot of people in our community trying to prevent bad things from happening and staying on top of things. And here's one example. A parent writes that they have a toddler, 3 years old, with Marfan syndrome, no obvious symptoms of lung issues. What evaluation tests would you recommend, and at what age?
3 is challenging because they're not old enough to comply with what we would consider pulmonary function testing. Usually we start at about 5 or 6. I think it's important to, one, kind of place your toddler in the context of whether there are structural impairments in the lung. Does your toddler have a Pectus deformity? Does your toddler have scoliosis? And monitor your child closely in terms of how he plays. Does he or she tend to get exhausted kind of at an earlier stage than his friends or his siblings when he's playing, especially when he's exerting himself? Does he seem to have episodes of coughing or episodes of even audible wheezing? At that age, it's really important to kind of pay attention to how your child differs from other children who are of a similar age. And if you have older children who do not have Marfan syndrome, if you would compare kind of what he's doing, what he tolerates, what his exercise capacity is relative to what theirs was at the same age, that would be enormously helpful. And if you are concerned, please bring this up to his pediatrician. And again, ask for a respiratory or pulmonary assessment if you have any indications that there could be some reduced exercise capacity or some overt respiratory symptom.
Great advice. Should people with Marfan syndrome or Loeys-Dietz or another connective tissue disorder, should they do exercises to strengthen their diaphragm, abdominal breathing, or Qigong, which I do not know what that is. It sounds like something I should know and I should be doing probably. But can you talk about those exercises for people with Marfan? Would that help?
Yes, I am an incredible believer in strengthening your respiratory muscles. I mean, I have patients who have very significant kind of scoliosis with reduction in the lung capacity, who basically have excellent exercise capacity because they're involved in kind of an exercise program on a treadmill, on a bike. And so what this shows is that with kind of effort, you can really maintain a high level of kind of function and exercise capacity. But what's important is to come up with a program that you're able to stick with. What you don't want is to have the proverbial kind of, you know, treadmill in the basement that you use to dry your clothes on. So you need to pick an activity that is safe, but is also one that you enjoy. And as we know, we don't like a lot of resistance kind of activities with Marfan syndrome. And so activities such as walking, or when the COVID issue has resolved, going to the gym and picking machines that are not high resistance machines, but are aerobic machines that don't cause a lot of stress on your joints. That would be ideal. I'm also an advocate of doing kind of body work in terms of yoga and things of that sort. But what you don't want to do is to use lots and lots of resistance. You don't necessarily need to build muscle. What you want to do is build endurance and exercise capacity. And so I would start off with biking, treadmill, walking, and then I would, once gyms are available and open, and then play around with the machines that are available there.
Great, great advice. Exercise is good for everybody, as long as you do what your doctor says is safe for you. So we have guidelines on that on our website. So
yeah, and it's also, and now I think because of in the COVID universe, there are all sorts of Zoom communities where you can find a group of people who are starting an exercise program, and for a variety of reasons. So you can create your own community of people who will kind of help you stay with it.
Well, I don't know if I'm supposed to tell everybody this yet, but I will tease that we have the Marfan Foundation has a big announcement in 2 days. It's going to involve a group activity that's not competitive, that involves walking and joining with everybody worldwide to accomplish a goal. That's all I'm going to say, but watch for that in 2 days.
Oh, great.
So, just remember this conversation tonight, and I told you, so you have a heads up. So watch for that on Thursday.
You whet their appetite.
Yes, exactly. I want them to be excited when they hear about it. The sleep apnea pillow, you mentioned it briefly. There's been a few questions about it. So is that something people should try before they go for CPAP?
No.
Okay.
I'm somebody, and you have to recognize I have this posture of, I want to basically treat sleep apnea aggressively because I don't know whether that's a major contribution to aortic injury. So the intervention of choice is always going to be nasal CPAP. And I want people to realize that there are so many choices in terms of the mask. You don't have to go on the internet and see the alien mask that's kind of crazy looking and say, oh my God, I don't want that thing. Now the masks are really, really limited, and many patients use them and they're not so horrific. So please don't get scared off with the prospect of using kind of one of the masks. We have nose-only masks. We have masks that cover the nose and the mouth, and there are a variety of those. The nasal pillows are typically used kind of as an adjunct to kind of other treatments for sleep apnea. And the other kind of aspect of these treatments that I think is important is that there are dental requirements for using the dental devices. And because we know that there are dental impairments with Marfan syndrome, sometimes our patient population are not going to be the best candidates for some of those devices.
Okay, great. So I'm going to share my screen for some final thoughts here. And if you were here last week, there are some new final thoughts, so you don't want to leave yet. Some of them are the same. Of course, we thank Dr. Neptune for all her time tonight. If your questions weren't answered, please submit them to marfan.org/E3ask, and please be patient. The volume is high, as you can imagine, and Jan in our help center will answer them. If she can't, she will tap Dr. Neptune for her advice, as she always does. Again, please complete the session survey. I showed you where that was earlier. Visit the exhibitors in our virtual exhibit hall. They're really important supporters to the Marfan Foundation, and again, they help make these kind of programs possible. So please visit them, watch their videos. They're all really short, but they're really great supporters. Keep connecting with community in the app. There's so much of that going on. If you'd like to share what you're learning or how wonderful this is on social media, use our hashtag, please. Hashtag E3Summit20. And if you'd like to help make more programming possible, we are always grateful for your donations, and that is at marfan.org/donate. And what's new that I want to chat about briefly after this summit is Aortic Disease Awareness Week coming up September 19th to 26th. It's a worldwide event powered by the Marfan Foundation, and we hope you will participate in our awareness project, which is being led by Dominga No, who was in the chat box with you all. So our project is about raising your hands to raise awareness of the risk factors for aortic disease. So information will be in the Summit app this week. It's also on our website and our social media. And so we'd love to see your pictures with you raising your hand to raise awareness of the risk factor that you have. So before we close tonight, I just wanted to give Dr. Neptune a chance to say some final words and help us close out tonight.
Well, I just want to thank the larger community of persons with Marfan syndrome and related disorders and their caregivers and their families, and just say I am so impressed with their enthusiasm, their intelligence, and their interest and their self-advocacy. And please, please let me know if I can be of any help to you. And please kind of continue to kind of weigh in with the Marfan Foundation and help us to deliver the best care possible.
Great. Well, thank you so much. And thank you everyone for joining tonight. We have a few more days left of the summit. We hope you continue to get the information that you need to live a long and great life. So thank you so much. Have a great night.